So are we ready to kick it off?
Let's go.
Perfect. So, hi guys, welcome to this event today. My name's Sam. I'm the president of X-Posure, the Leeds Undergraduate Radiology Society. So we run a lot of events to do with radiology, and we're really happy to do this event in conjunction with the Leeds and the Birmingham Extended Realities Society to kind of show you how XR can be used in medicine and particularly radiology. So I'll hand over to those guys to talk to you a bit more.
Yeah, hiya. It's really great to be here. I'm really excited about this collaboration. This is Leeds XR Society's first collaboration, and we're looking forward to doing more in the future. So yeah, a little bit about us. We're quite a new society, but we are aiming to be able to connect industry, academics and students together to be able to shape and work together to influence the use and the power of XR technology in society. So yeah, this is a great event, and we're looking forward to the speakers speaking for us. And University of Birmingham.
Cool. So hi everyone, my name is Ramsha and I'm the president of the Virtual Reality Society at the University of Birmingham. Similar to the Leeds XR Society, although we have VR in our name, we do focus on all different types of immersive technologies used within different industries. And we have a similar aim to just spread the awareness of the use of AR and VR in different industries and just help our students explore the different technologies. This is actually our first event, so we're really excited to have all these amazing speakers and to be collaborating with Leeds XR and Leeds X-Posure. And we look forward to just having a lot more future events with both your societies. So thank you. I'll hand over back to Mohammed now. Thank
you very much, Ramsha. So I think it's probably good to crack on. We're recording the event and it's also on Facebook Live. Our first speaker today is Dr. Dimitri Amiras. He is an experienced radiologist with a demonstrated history of working in the hospital and healthcare industry. He qualified from Imperial College School of Medicine with an intercalated degree in medical imaging in 2004 and now specializes in MSK imaging. He has a keen interest in clinical research and medical education and has incorporated mixed realities into some of his projects. So without further ado, over to Dr. Amiras.
Hi everyone. Well, I'm just going to share my screen. So this is the most stressful part of any presentation we do nowadays. Hopefully that will work straight from the beginning. Look guys, thank you so much for inviting me to come and talk as well, because it's really, I'm really pleased to be involved in your societies and to try and promote, we're going to call it XR or extended reality. And I'm really glad to see as well that you've thought about radiology and it's come up near the beginning. So those are the two things that I'm really passionate about. So I'm really excited to come and talk to you guys today. So without further ado, I'm just going to talk a little bit about where I work at the moment. So this is part of St Mary's Hospital Medical School, the old medical school building. Unfortunately, it's going to be sold this year, but just around the corner from this plaque was where Sir Alexander Fleming discovered penicillin, and it took about 12 years after the discovery of penicillin before it was actually used to treat a patient. So there is a good history of kind of developing medical technologies at Imperial and St Mary's Hospital, but I just wanted to give you guys a bit of an idea of where we were down in London. So just in terms of declarations, I've been a paid speaker in the past for Microsoft. I'm going to talk to you today about why we need XR, what radiology's role in XR and healthcare is, and then I'm going to talk about some of the examples I've been involved in, and some of my colleagues that I've been working with are going to talk about those in more detail. So I'm not sure how much I need to tell you guys about this kind of XR term. When I was at medical school, there was virtual reality and augmented reality, and that was about it. And in the last sort of 5 years, we've seen terms of mixed reality, immersive reality, and basically that just shows that there's such a spectrum. It's not just AR and VR, there is a spectrum between them, and that's just how much you use the digital world and the real world. And I think the reason why we've seen such an explosion recently is just the degree of computing power we have, and also the amount of technology that we've got to actually harness information. So why do I think it's important? So I think one of the two key areas are training and in clinical practice. And I'm going to talk about both of those. So firstly, I'm going to talk a bit about training. So I know Mohammed is thinking about interventional radiology, and interventional radiology is kind of still taught the way that Halsted started teaching surgery. And that is what's called the Halsted method, where you watch an expert and you learn from that expert, and you do quite a few procedures watching them. We've gone a bit further forward in that in radiology. So we have something called direct observation of procedural skills, or radiology-based DOPS, and that's a kind of reflective-based learning. And I'm sure most of you are, as you're doing education at the moment, you're probably more used to this kind of thing. But really, in radiology, we haven't changed very much in that. So one of the things that we found is really useful, is just starting to become useful, is simulation. And the trouble with simulation is it can be quite expensive to do. There's a couple of papers that showed simulation of a CT biopsy technique or CT injection techniques, where they just put a simple box with some jelly inside, and they put it in a CT scanner, and they used that to simulate the procedure of taking a biopsy. And actually, that very simple procedure reduced procedure time, reduced radiation dose, improved efficiency, and actually what was really important is it improved the confidence of those people that are training, and it ultimately will improve patient care and safety. And the problem at the moment is that we just haven't got CT scanners that we can put aside, or fluoroscopy rooms that we can put aside for people to go and do these simulations. So I think XR has got a really important role to play in low cost simulations. So this is an example, and this is basically an ultrasound scan. So for those of you who aren't sort of medically based, you do an ultrasound scan of the kidneys, and it's one of the first kind of things that you learn. And the best way of getting a good appreciation of the kidneys is actually to scan from the back, and we can look at the back and we can see the kidneys. Now, one of the things you have to do is try and get the length of the kidneys to work out the size, and that can be quite difficult because you've got a 3D object and you're trying to put a line through it to make sure you get the longest appreciation of it. And just to learn that skill with a very simple application on a mobile phone, teaching you how to find, using the visual cues to find the longest length of the kidney, actually improved radiologist skill as they were training. So even just like a really simple application like this, it looks very kind of 90s, 80s games, made a real difference. And there are other examples in ultrasound where these ones are a bit more complicated, but they still use virtual reality and they use phantoms, and they can really improve the fidelity of training and make training easier and more accessible. Those of you that are medical students, you know about the kind of can be quite stressful going on towards seeing sick patients, lots of other doctors around. It's probably not the best environment to be learning in. Somewhere safe like this is much better for that kind of thing. And then moving on to the clinical stuff, hopefully all the medical students in there will recognize this, and the other students and other participants may recognize this as the WHA surgical checklist. Now, this was brought out in 2007, and it was used to reduce unexpected events or serious untoward events in surgery. And it's really well recognised that in healthcare there is it's not as safe as it can be, and we look towards the airline industries and stuff like that to try and improve the safety within healthcare. And one of the things that are really important are checklists. And one of the most important things on this checklist has is any essential imaging being displayed? And at the moment, that's displayed potentially on a screen or in a computer around the corner from when the operation is taking place, but it's not right there where the surgeon is looking at it. And this is an important thing. We're now looking at complex scans in radiology, and we're producing these multi-slice images at several gigabytes of information. And how are we communicating that? Well, we've got these images, but you can't just look at them and work out what's going on. So people like myself, radiologists, will write a report, and typically we write these long wordy reports. It takes a long time to read through them, and it's not a quick response to go and to talk about it. And did we really capture all the information that was in here? Did we really explain that? And is that understood by the person who's reading it in the same way? And you can't look at that quickly while you're going through a checklist. It doesn't work like that. So how can we communicate that information to other surgeons? So as a radiologist, I used to do a lot of Lego. Any potential radiologists out there, the 3D appreciation and this cognitive spatial awareness is really important for understanding the 3D that's coming out of the 2D images that you're looking at. And I will have a different understanding to stuff to the way a surgeon will understand it, or perhaps a medic will understand it. And if we use the XR field, we can actually make that communication very simple. So the other problem that we have is our techniques are now getting more and more advanced. Over here, this is an example of electrophysiology in the heart. And you can see here, this is the right atrium, pulmonary veins coming in here, and you can see the electrical flow running through this. And this is a 4D image, a 3D structure. Now, it's really difficult to put that into words. How could you describe that image? And even if we're showing it to you in 2D, there's still a lot of information there that we will get much better from looking at it in XR. Similarly, this is a spectral CT scan, and we're just getting so much more information than we did before. We don't just have black and white images, there's color, there's loads more functional information in there. And I think XR is definitely a way in which we can express that better and communicate that information better rather than just using words or simple 2D pictures. And I think Mohammed will like this. So this is a recent paper that was published, and actually I have to thank Thomas for showing me this earlier today, actually. So this is a augmented reality guided procedure. So this is a biopsy that's being taken. Well, this isn't a real patient. This is a phantom, but they've instead of showing the needle going through slice by slice, and you'll see that a bit later with the simulator that we built. This actually shows you the trajectory that the needle's going into the patient while you're wearing the headset. So, I mean, this is changing the way in which this is going to change the way in which we do things, and the ease at which we can do these procedures and the less discomfort that patients will have. And this paper showed that it potentially reduces dose, reduces the number of times you have to puncture the skin. So going back to the clinical practice, this is about communication, and this is actually my bedroom. And I was trying to explain to my builder how I wanted my cupboards, and I kept explaining it to him. He didn't quite understand what I meant. In the end, I decided, why not? Let's use some XR, and then I just drew it onto them. And there's no confusion then, and people understand what you mean. And I think that's the great thing about using XR, and especially sort of mixed reality, augmented reality. There is a really great way of communicating the information in a really simple fashion. It's not thousands and thousands of words. It's just a really simple picture, and it's a really great way of communicating complex information. So I'm going to talk about a clinical problem that we face in radiology, and we call these people plastic surgeons. They're very demanding and they're very precise people, and that's because the job they do is really tough. But they have to deal with these people, and I'm going to call them Paddington people, but you'll have your own version in Leeds. But we are a multi-trauma center. We see really complex traumas that come in associated with open wounds that require lots and lots of surgeries to fix the skin to fix the bones underneath them. And they require what we call flaps, or reconstructive flaps that go over the area that the skin's been damaged after the kind of bony problem's been fixed. And one of the flaps that our surgeons like to use was called the medial sural artery perforator. And that's just something that comes off the back of the knee. And it's been described as having these 4 different potential blood vessels that come off at different types of anatomy. So every single person has got one version or a variant version of this. It's not simple, just there's your radial pulse, there's your ulnar pulse. It's much more complex than that. And so we were scanning these patients to give surgeons an idea of the anatomy. And again, I had the same, and this is the flap they were trying to get. They were trying to get those little blood vessels and take the skin from here and take it all the way back down to the knee where it came from, and then put it somewhere else. So we had the same problem before. How do I communicate this to my surgeon? How do I tell him exactly where he needs to go? And actually, even before that, we had to work out where these perforators are. They were actually really difficult to see. This is actually my own leg, and I was trying to find my own perforator, and there it is. And we found out actually that it's better seen by the veins rather than the arteries, even though there isn't an artery in the vein. So we discovered there was a really nice technique for doing this, where you put a band around the legs to keep the blood veins dilated, and you give them a different type of contrast. So you give them contrast that starts right at the beginning of the scan, and then right towards the end of the scan, you give them some contrast so we can see the arteries. So right at the beginning, the veins start to fill up with contrast, and then right at the end, we give them a little bit to show the arteries. And then we got these really beautiful pictures, and we could draw these like fantastic silhouettes around the blood vessels and draw these images. And when it came to the surgery, the surgeons still didn't really find this that useful. We were drawing, we're taking a ruler, and we were drawing on the leg and trying to find, and they were trying to do the same thing. And I just thought, you know what, we can do this so much better. As much as I describe it to you, your version of where the medial malleolus is and mine could be slightly different. Where I think this is a good vessel, a bad vessel, you may have a different interpretation of that. So we ended up doing a project with Philip Pratt, and he's going to tell you about how we use this particular example in mixed reality. So hopefully Philip is ready to take over, if I haven't taken over his time too. Oh.
Yeah, I'm ready to take over.
Fantastic. So I'll just stop sharing.
I'll start sharing.
So that just while Philip's preparing the screen, these operations happen really quickly. So we had to turn these around. These scans, we used to have to turn them around in, sort of 12 hours or 24 hours overnight for the surgery the next day.
Yeah. Okay. Well, I think I'm ready. Do I need to introduce myself, or?
Oh, shall I do? I can. Oh, Mohammed can do that.
Okay, I've got a formal one, although Dr. Amiras, maybe you have a better one. I'm not too sure. I'll say what I have.
Yeah.
Yeah, absolutely. So our next speaker, really nice transition there, is Dr. Philip Pratt. He's the appointed research fellow at the Hamden Center for Robotic Surgery at Imperial College. From within the Department of Surgery and Cancer, he now undertakes a very active research program in the field of image-guided surgery. He has also successfully translated new technology and software into clinical practice in the operating theatre, and is also Chief Scientific Officer at Medical Eyesight.
Thank you.
Thank you, Mr. Pratt.
Yeah, so I should maybe point out that so my former role was in Imperial. I've now stopped being an academic, and I'm spending all of my time trying to share, trying to get this technology into clinical practice, and the vehicle for that is the startup that was just mentioned. So, putting lots of effort into clinical translation, which is my real focus in all of this work. And what I'm going to talk to you today about is following on from what Dimitri was saying, a project we did together essentially 3 years ago now. It was published at the beginning of 2018, where we took XR technology and took it into the operating theatre and started applying it to real patients, real people. You know, the motivation for doing this, I mean, you know, one can use the technology and appreciate it in its own right, but really my motivation is to create software and tools that can be used to improve patient outcomes. So that's what sort of the driving force behind this. And you know, it just so happens that this technology exists now, and it's really for certain applications. It's very promising indeed. So I'll hopefully won't overlap too much with what Dimitri said, and I'll just launch into the presentation, which will be a bit more of a technical nature, because I'm essentially a software engineer and mathematician by training. So again, just to recap on the clinical problem, you know, what the XR technology is not a panacea that's going to fix everything. You've got to start with and understand your clinical problem, and then apply the technology if it's appropriate, and you can be confident that it's going to make a difference. So there we go. Apologies for the gory images, but if you can imagine having had an injury where some of the tissue has actually been removed, this isn't going to heal by itself. You need to raise one of these tissue flaps and plumb it in to the target site where the injury is. And the key is to know where the vessels are in the leg when you harvest that flap, so that you make sure essentially you've got enough plumbing there to connect it all up. If you were just to take that that flap of skin and tissue and transpose it to the injury site, it would die within hours, because it doesn't have a blood supply. So knowing what the vasculature is underneath the surface is key, both to execution of the procedure and also to planning of the procedure. So hence having tools, mixed reality headsets and so forth, that essentially give you X-ray vision. They allow you to, that's the sort of simple description of the one-line description of what we're doing here, is giving surgeons X-ray vision so they can make better decisions during surgery. And it also can reduce the amount of time taken to perform the surgeries. These plastic and reconstructive cases can sometimes take all day, maybe up to 10 hours. If we can reduce the time for those cases, you may be able to do 2 in one day. So have an operating list with 2 cases on. That will save a lot of time, but also valuable NHS resources. So that's the clinical problem. And again, you've seen this picture before. This is the flap that's raised, and you can see the blood vessel that's being harvested there. And what we want to do is to make sure that when the surgeon wearing the XR device looks at the leg, they can see what's going on underneath, so they make the incision in exactly the right place. So again, these are the images from which the models that we use in the software are made. You can probably just about see there through these axial cross sections the locations of the vessels that we're interested in, but they're pretty small. But you know, we have software that can, and trained radiologists, experts like Dimitri, who are good at picking out these subtle anatomical details, to create 3-dimensional models, because that's what we're going to render on the devices. And again, you can improve the quality of the scans by making sure that you get a good contrast enhanced acquisition. So again, this is where Dimitri's expertise comes in, and why this project was successful, because we brought different skills and knowledge to bear on the same problem. So there was a very good mixture of clinical and technological expertise. So what you're seeing here is the legs being raised to make sure that the contrast pools, so that when the scanner acquisition takes place, we get really good pictures with good contrast. So again, you can see now that in these images, the vessels in the periphery, they're much brighter. They're showing up because they have X-ray contrast in them. And what Dimitri's done here is to highlight with these arrows the positions of the perforators that come through up into the upper layers of the tissue and the skin. So I'll just rotate this round. So what we want to do is to essentially recreate this model inside the XR device, so that when we put it on and when we register that with the patient, we can essentially see inside them and see what's going on. I think we're almost at the end of this sequence now. I don't want to go too far. There we go. So you get a full kind of 360 there, seeing what's going on with those vessels. So the device we used was the Microsoft HoloLens. You may see that this is the version 1. Of course, version 2 is ubiquitous now. When we did this work, it was basically as soon as we could get our hands on a HoloLens 1, we started. And because this work was published 2 years ago, HoloLens 2 wasn't around then. So it's all this is done on the first generation of the system. And I know Dimitri mentioned earlier about the time constraints we were working under. We didn't have very long to prepare the data, so having an efficient data pipeline was very important. So I'll just quickly run through that. So the scans were acquired on a high resolution CT device. This one was actually made by the manufacturer Philips. We get incredibly detailed pictures. Just to give you an idea, the resolution of each slice, you can see the detail down to under 0.5 millimeter, which is incredible. Then what we do is to take that information and to segment it. And by that I mean you're essentially annotating the structures of interest. So the blood vessels, maybe the bone, maybe there was some metal components in there. So quite often with these traumas, you have broken bones and so forth that also need to be repaired. And sometimes, you want to include those in the models as well, because they're part, they get in the way in the operations, or you need to work around them. The third stage is to generate the models from that raw segment. Sorry, some background noise. And we do that using some sort of standard computer graphics techniques where we apply smoothing algorithms and mesh decimation just to reduce the polygon count down, because again, going from a 0.5 millimeter resolution to something that can be rendered on a relatively inexpensive, not particularly powerful device, you just need to be careful about making sure it runs very quickly and is interactive. So that's the stages 3 and 4, and then the final stage is to load that up into an app. And at that stage, this was essentially a clinical prototype that had voice control and other gesture controls to spatially manipulate these models so that you could do a manual registration. So here's another slide just showing a bit more detail on the models. So we essentially replicate what Dimitri produced in his clinical applications. So there we've got the outline of the skin, the bones, some registration fiducials, the vasculature, and the arrows pointing to the areas of interest, which is where the perforators come through the fascia. So this picture was taken during one of the cases. So we did 6 operations in total, and this is basically the surgeon's eye view. So it's a real patient data overlaid onto the patient during the operation, and you can immediately see that it's a good registration, and you can just, as I said at the beginning, it's like having X-ray vision. You can see inside the patient. Here's a different picture from essentially from a second person wearing a HoloLens. So we were allowed to link them to. We were able to link them together, so you could have 2 surgeons wearing but seeing the same mixed reality, extended reality view. So that's a different operation. It's another one of the 6 that was done in 2017, 2018. Here's a short video that just, this isn't a real patient, this is a dummy in the lab, but it kind of shows you how you might register this leg to the real leg manually. You can use the knee and the malleolus, which is the ankle bone, as registration points. Obviously, what we want to do in future is to make this registration automatic, so that you essentially just look at your patient and it snaps. But that's a slightly more challenging computer vision problem. You know, we were very keen to get this technology into the OR. You know, even if it requires some manual intervention, because you know we think it's really useful, and again, as I said at the beginning, can have an immediate impact in terms of improving patient outcomes. So what we did was to, you know, this is a scientific process. We need to validate what we're doing. We need to measure objectively how accurate the registration was and so forth. There's no point doing this if it doesn't actually, where you see with using the software, it doesn't actually represent where the vessel was. So we confirmed the locations with Doppler ultrasound, which is another technique for picking up those vessels, but it's a bit kind of hit and miss. You have to essentially go search for the vessel by moving this pen-like probe around until you find the right sound, because it's picking up the blood flow. And in all the cases, we were within a few millimeters of the target. So, and then of course the acid test is when you open up the leg, like that, you can see on the skin some markers, which is where I think one of those crosses was where the HoloLens perforators were, and you can see there, just in between those two instruments, you can see the vessel deep within the muscle. So essentially, we were right on top of the vessel. So that helps validate this procedure. Obviously, we need to do more clinical trials, collect more data, just to you know, to prove scientifically that this is working, is accurate and safe. Just a quick summary of the cases. There were different types of perforator. So Dimitri mentioned the medial serial artery. There were other arteries in the leg that were used, and other different types of flap, where you either take the entire piece of skin tissue, or sometimes you can just twist it around and stitch it back in. So there were different types of operation. Obviously, everyone's injuries are different, everyone's legs and their vasculature is different. So here's the publication in European Radiology Experimental. That was back in February 2018, and it's open access, so you can look it up online, and it's there's a lot more detail in there should you wish to sort of delve down a little bit more after this talk. In terms of where this could be taken next, we might want to introduce volumetric rendering as an alternative method for visualizing the scan data, because you can then avoid the segmentation step. We want exogenous tracking, so that's where you might want to automatically register the virtual anatomy to the real patient's anatomy. State selection is just essentially my way of describing being able to pre-store different settings for different cases. Again, during surgery, time is often of the essence, so anything you can do before an operation to set things up already is going to be helpful. Preoperative planning, so again, if you can do as much work before the operation as you can using this type of technology, that's going to be beneficial in terms of time. Points of interest, so this is again to do with registration. Can we get the software to automatically locate various anatomical landmarks, including, for example, the malleolus, the ankle bones, and also the knees, in order to do an automatic registration? There are other types of tissue flap in the body. So there are these so-called DIEP flaps, which is deep inferior epigastric artery. And these are used to close the wounds after breast reconstructions. And finally, other surgical specialties. So we're talking here about plastic and reconstructive surgery, but there are other areas of the body where XR technology could be used, including neurovascular procedures for the treatments of strokes or aneurysms, also cardiac procedures. So it's applicable both to open surgery and minimally invasive surgery. So with that, I will hand over to Thomas.
Thank you ever so much, Dr. Pratt. It seems that you either have some DIY happening at home or you've got some orthopedic surgery next door. Hopefully it's the former rather than the latter.
Yeah, there's some sound outside. I'll mute myself now.
That's okay. I see that, Dr. Amiras, you've seen some of the questions in the chat. If you can kindly see to some of them. I understand that time is not that ample, but you can definitely give a few a shot.
Do you want me to answer them now?
Yeah, go ahead.
Yeah, so let's see. So I think Valeria had a question. Is the segmentation automatic or manual? So the answer to that is it's semi-automated, but it's done. So I did them all using a computer program called Vitria, and it's got special sort of semi-automated methods to find vessels. It's really important there is a human in that process because you know, there's an operation that's taking place because of the bit that's been found. So I think it's really important at least it's validated. And yeah, there's quite a lot of work going on, especially in the artificial intelligence field, about automatic segmentation. But I think one thing that's really important is that there is a validation of that, and then also how that information then goes to becoming a mixed reality object that is then matched to a patient. All of that fidelity must be kept along the way to make sure that it's safe and reproducible. And then how is the model registered to the patient service anatomy to ensure the patient's data is accurately overlaid? So that was, so in that particular case, it was done without any exogenous markers. It was literally done by eye. Luckily, with the lower leg, you've got your kneecaps and you've got your foot, and with that, we were able to get actually really good approximation. And you know, that's in terms of measuring the registration accuracy. It was literally the actual thing that was important, which was the operative field and where that perforator was. And then there's a question from Sanjan asking about the workflow for converting images into 3D models. So yeah, that's not automated yet, but could, you know, that's definitely part of it. And even though there'll be some semi-automated processes of that, you want to make it for the radiologist very simple. So yeah, that's a good question.
Just to add to, please, I think when we were originally doing these, it took us about maybe half an hour end to end, because we weren't automating much of the intermediate stages. So we have automated some of those processes, but we're not using those in clinical practice yet. So in the sort of test setup, we can get that time down to a matter of minutes. Ideally you want to take the scan and then have the data flow through to your target device within well, basically as fast as your network allows. The processing should take seconds, but as Dimi was saying, some of these scans can be up to ½ gigabyte in their source format, so it does actually take a finite amount of time to get them from A to B.
Yeah, no, totally agree with that. And I think one last question from Nathan said, will or could this system be used with universities for creating training scenarios? And could you change the variants of the conditions I put in a fictional emergency? So yeah, I mean, I think that's a really, you know, great question. Could we, you know, create variant anatomy and then create a training scenario where that changed? And I think this actually really nicely brings us on to Thomas's talk, which is going to talk a bit about a training example where actually we could change some of the conditions. So I'll go to Mohammed to introduce Thomas for us.
Absolutely, thank you so much. I was just wondering, actually, on the topic of the model registration, would you, I'm just giving Thomas a bit more time to set up the slides. Yeah. Would you consider in the future adding some stickers, like maybe 3 different colored stickers on the skin, So that becomes a surface marker during the sort of picture acquisition phase, and then you can use it again when you put the headset on. So the headset recognizes these 3 points, and based on that can scale things accordingly.
Yeah, so definitely the use of fiducials is quite ubiquitous at the moment in neurosurgical navigation, and certainly there are lots of studies that have used that. And in fact, the one that I showed you with the biopsy, that actually was quite clever because it used the grid that we normally use in radiology to work out where we're putting a needle, and it actually recognized that grid and used that as a marker. So the real aim is to go markerless and to be as accurate as you can be markerless, but actually, as Philip was alluding to earlier, you actually just want to get using the device. You want to get the information from actually using it to seeing what's useful and what really makes a difference. But yeah, there's lots of really good work in terms of how you can bridge the gap anatomically. Yeah,
that would be interesting from an accuracy point of view, obviously.
Yeah.
Very good. So our third speaker today is Thomas Hurkxkens. Hopefully I've pronounced that correctly. His aim is to bring together teachers, students, and creative professionals to design effective and engaging academic education using visual and immersive technologies. He's been involved in multiple initiatives, including education and healthcare pioneering projects that use immersive realities. So without further ado, over to you, Thomas.
Thank you very much for that introduction, and yeah, great to be part of this event. It's really interesting. I've been working with Dimitri and Philip on a AR and VR application, but this time on the training side, so for educational purposes. It's very different from the clinical application of augmented reality. Yeah, just let me run through the slides. What I want to talk today about is a little bit of context of immersive technologies at Imperial and our design approach. So how do we actually develop these educational solutions together with academics? Then I want to share a little bit about the CT-guided biopsy application that we co-created together with Philip and Dimitri. And then finally, I want to share a bit about the network of the academics we have at Imperial, our immersive technology initiative. So yeah, Imperial College, immersive technologies. There's a lot of interest at the college, as I think globally, in the use of these technologies. So where do we see that potential, right, of applying these technologies in education? So first of all, we see big tech companies, we see the interest moving towards using this technology basically across, right? So in many areas, but education as well. Where we see a lot of potential is that in our remote education, and now especially that many students are remote, we see there's a lot of potential to learn theory, but there's limited potential to actually apply your skills as a student. And we see that these technologies can actually create these environments where students can apply their skills and practice and basically learn in a safe environment and learn over and over again, basically when and where they want. So that is a very new way of learning and a very interesting one, and a very much needed one, I think, in the current context where we find ourselves. So how do we go about creating educational solutions using augmented reality, virtual reality in our education? So I work at the Imperial College Digital Learning Hub, and our hub basically brings together different expertise around the academics and the students to design these applications. So we bring in learning design, and I think, like Philip mentioned, starting at the clinical problem is key when you want to create a clinical application. For us, starting at the educational challenge or learning outcome that we want to achieve is key. And we have learning designers that then work with the academics to identify that learning outcome that we want to achieve. We then also, in these same sessions, have that technology expertise. So having a developer there that can translate the ideas of academics and students into a virtual reality application and obviously then also project support. And what we do with our applications, I'll share some results of that later on as well. But we obviously have that action research or a very strong evaluation of the applications that we create, and are they actually effective learning tools for education. Well, together with our academics, we have these multidisciplinary sessions where we map out the experiences using a experience map. You can see a small section here, basically starting at the learning outcome, but then really mapping out the experience step by step all the way to the end, and also thinking about how to assess the experience. Well, what are then some of the examples of the projects that we do at Imperial? Well, one project I really like is in anatomy education. Well, common practice in anatomy was to basically show students the anatomy and then assess their knowledge based on multiple choice. But we decided to change that and actually create an assessment, an exam, where students would look at a 3D model of the human anatomy and being assessed that way. And that allowed for different questions to be asked, also to the relation between movement and muscles and nerves. So it was a really different way of assessing the knowledge of students that worked really well. And the feedback of students was really positive on that. In another application, we overlay the skin of the students with skin conditions that students can then diagnose on each other. So we used a phone or a tablet to overlay that skin condition in augmented reality. And a recent project that is really interesting, I think, is that we now use the Microsoft HoloLens to take students onto the ward and basically allow students to participate in taking a history on the ward, even now that they are remote. So students can look through that HoloLens onto that ward, and the clinician can add different learning materials, like you can see here. For example, a CT scan added into that learning environment, and students can then participate, communicate with that clinician, but at the same time see these additional learning materials. And I think it's a really nice way to still be able to deliver these ward rounds, even though, we're obviously, there's a big challenge at the moment now with the pandemic going on. And finally, we do a lot of project with students as well. At Imperial, we have a summer program where students develop together with academics simulations for education. And there's a lot of interest to participate at Imperial. We put up a poster for 3 days just to ask for some students to participate in the development of these applications over the summer. And after 3 days, about 70 students applied for working with us to develop these simulations. So we see there's an enormous interest also in the student community in working with these technologies, which we think is really great, because students are often the expert, I should say, when it comes to these technologies, and the academics and we as staff have a lot to learn. Well, going from the more broader picture of AR and VR at Imperial to the practical application that we developed together with Dimitri and Philip. So what we created is basically a CT-guided biopsy simulator. What we want to achieve with this simulation is that the training is more accessible for students. Students can practice when and where they want, like I just mentioned. And I think we had a nice challenge here, because in medical education, it's great to simulate something, but the additional challenge is, how do we introduce that haptic feedback? How do we really make sure that when you do a simulation, you actually get that feeling of what it's like in practice, right? So that we make that closer connection with reality. And I think that especially in medical education and training, that is really important. And I also should mention, Dr. Mohammadi here, who worked with us on this application. Okay, so what have we developed? I can share a short video of the application in action. Just run it.
I'm delighted to work with the Digital Learning Hub team at Imperial College to provide HoloLens augmented reality simulation training for the first time actually in the world in this particular field, in this particular setting as far as we know. Today we have invited junior trainees to have a simulation course in the core IR or interventional radiology skills. They are practicing guiding biopsy needles and drainages into target lesions. The simulation they are working on is constructed from real patient CT, and they are using real needles and ablation devices. The HoloLens simulation provides us not only with accurate imaging placement, but also with the tactile feedback, all done within this augmented reality. It's very fascinating indeed. The field of interventional radiology is expanding, not only in terms of the number of procedures, but also in the complexity of the procedures. This sort of digital learning technology will help them to provide the services at much higher technical ability and safety. It is very interesting to watch the trainees and the trainers today. Everybody is so excited and so engaged in it, which I think it shows another dimension of it, that you are training people in a very friendly and attractive atmosphere.
Oops. Yeah. Okay, so that was a short video with the basic explanation. Let me just grab my presentation here. Yeah. So basically, what we did, we used the Microsoft HoloLens to project 3D anatomy of the torso over a gelatin phantom that we used to simulate the patient body. The Microsoft HoloLens provides a great way of getting it familiar with the room around you. So it maps the room around you. It knows what hardware is in that room in front of you, basically. And the RGB camera can then detect markers and place virtual objects in that room that relate to the real world. So that mixed reality environment. So what we did is we took a Charuka marker for this to track both the position of the phantom as well as the position of the needle. And basically with voice commands, we could then move through the CT slices that we had projected in the HoloLens as well. So it was a really interesting way, because working with voice commands for this simulation is very similar to how such a procedure would go in practice as well. So we used the 3D anatomy. We projected also in the HoloLens that the CT slices, and we had a real needle with the real gelatin phantom and a virtual needle that is then again tracked by the HoloLens, and a virtual representation of that needle is then seen in that CT scan. So just to show in a bit more detail what's going on.
Scan.
So here you see in the CT slices the virtual representation of the needle and the target that we are aiming for with this simulation to hit, right?
Next. Previous.
So as you can hear, you can move along in the slices with next and previous, basically to find that representation of the needle and to make sure that you locate it. And as you advance the needle, you can then update those CT slices to then get that representation of the needle to make sure that you're in the right location and that you don't hit any structures you shouldn't hit with that needle. And by the way, I'm explaining all this without having a background in medical education myself. So I think at a point it will be really interesting to hear also from Dimitri and Philip about this application. And if they want to contribute to the explanation, more than welcome to jump in here, Dimitri.
So I was just putting in the chat actually that those of you who can recognize the voice, that was actually Philip, and he's done it really well. So we managed to train Philip up to do lymph node biopsies in a very short space of time. So, but yeah, no, I think, you know, this, a lot of you probably don't have experience of this kind of procedure, but it's and Thomas will go on to show that actually it was really kind of high fidelity in terms of the procedure and how it's done.
So just a still image of the simulation that we just saw, just to again show you the virtual needle and the representation of that needle in the CT slices. We had multiple exercises, so we had objects that were harder to reach, and objects we started with a more straightforward case. And I think that's one of the advantages to work with these virtual simulators, is that you can quickly update actually the cases and the scenarios that you want students to go through. So in this case, you can see the more straightforward case here, and then the more harder to reach objects here. Yeah, and one of the things we did is we asked the students for feedback. So basically we ran a feasibility study in the use of the technology. And you can see that the overall feedback was very positive on the procedure. It was felt to be realistic, and also again that haptic feedback that comes from the gelatine. I think that is just a really strong asset of this simulation, and introducing this haptic feedback in medical education is, I think, very powerful. And yeah, a mixed reality device like the HoloLens allows us now to do that in a new way. So this is one of the applications we develop, but we see potential for much more. And again, also that confidence that students feel after running through such a simulation. And that's also relates to where we see these simulations fit in medical education. So we're not trying to replace the real thing with a simulation, but we see it very much fit between theory and the actual practice. And that as a student or as a trainee, you have just more ability to prepare yourself for practice and to build your confidence and your expertise. And if you have built that in a virtual simulation, we experience that students feel better prepared for practice and feel more confident when they are in practice. But just to make sure we're not trying to replace anything in practice. So what do we see as next steps to this simulation is, firstly, we want to try and see if we can do this simulation remote. So a trainee will be on location, having the simulation in front of him, and an instructor will be remote. And we want to explore if we can transfer this application that is now built for the HoloLens to more scalable devices like the iPhone or the tablet. Well, and then finally, to wrap up, this application is we built it together with Dimitri and Philip. It's part of many applications that are currently being built at the Imperial College, cross-college, basically, in medical education, but also in science and engineering. And to be sure, these are innovative academics developing this technology, and the Digital Learning Hub facilitates these innovations with learning design where we can. And this resulted in the end, so all these pockets of expertise where academics develop AR and VR technologies resulted in the Immersive Technology Initiative. And that is currently our platform, our website, and our network of about 45 academics now that work together and share expertise on how to use these technologies in education. And we do it with our great partners that help us in terms of learning materials, hardware, and build these applications together with us.
All right, that was fantastic. Thank you ever so much for that. We do have one question here. I wonder if you can see that, Dr. Amiras from Aditya.
Yeah, so the question is, could this have the potential to remove the need to view the CT scan while taking the biopsy, i.e. the scan is rendered so the location of the target can be viewed on the dummy itself? So yes, and actually I think one of my slides showed another study where they did something similar, where they actually identified it as an object, and you were able to put the needle towards the object without having to take a series of CT scans to identify that. Obviously, that's when the accuracy has to be, really spot on to make sure that you're getting the right thing. And the important thing about this procedure is that when you take a biopsy, you always have a CT image of the biopsy needle open, and you know what you've got inside there. So it's really important to make sure you get the target. But yeah, no, it's a really good idea, and I think that's the potential with these devices, that will end up reducing radiation dose, reducing the need to do scan and scan and scan.
Very good. I hope there's no more questions. So I think it would be good to move on to our fourth speaker, Dr. Justin Sutherland. If you're able to share your screen, please.
Sure. Thank you.
Fantastic. So I'll do a quick intro while you do that.
Sounds good.
Dr. Justin Sutherland is a clinical medical physicist at the Ottawa Hospital and an assistant professor in the Department of Radiology at the University of Ottawa, Faculty of Medicine. Along with his clinical role, he's interested in the research and development of clinician as user virtual reality medical applications, and he's also the co-founder and CEO of the company Realize Medical Inc., a medical VR startup that develops advanced 3D modeling, visualization, and communication tools that can be used to enhance patient care. And then there's a little bit at the end there. Don't miss the chance to hear about him speak and share his innovative work at Realize Medical, both in healthcare and immersive technology. So over to you.
Great, thank you very much. So thanks for the introduction. So I'll be talking about VR in radiology, healthcare, and specifically medical modeling. So just a bit about my background. So like mentioned, I'm a clinical medical physicist. So that is working in the domain of treating cancer with radiation at the Ottawa Hospital in Canada. I'm also a VR enthusiast in the form of video games. This is how I got started in this whole domain of research. So at the Ottawa Hospital and the University of Ottawa, we've done a number of academic research endeavors in terms of applications in VR and medicine. And then one of these things turned into a spin-out company called Realize Medical, of which I'm the co-founder. So today I'll be going over a little bit of educational material, talking about some of the concepts that we've come up with while we've been doing this work, and then a bit about the stuff that we're doing at the company. So a little bit of background in terms of understanding the roles of VR and AR in healthcare. So I find it useful to delineate these things so that you understand how the different applications differ from each other. And the easiest way that I've found to do this is to look at how these things stratify based off of patient involvement. So you start with applications where there's no patient involved, there's not even a patient-specific case involved, and so you have VR as a clinical tool. So either trainee or clinical education. Then you can have the patient involved in terms of it being their case, but they're not there. So these kinds of activities could be surgical planning, radiotherapy contouring is an application in my domain of medical physics. And then you include the patient a bit more. So now the patient is there during the procedure, and the clinician is using a VR or AR headset as they're doing the procedure. So this could be AR guided surgery or biopsies. So in this case, VR and AR is an intervention aid. And then you switch to the patient using the headset themselves, and you have applications where you have VR as a therapy. So phobias, PTSD, rehabilitation, this kind of thing. And then finally, a patient could have self-led education about their own illnesses without a doctor there. And so this stratifies into two different columns. There's clinician as user and patient as user. So in terms of patient as user applications, historically, this seems to be the applications that have had the most focus. And we think that this is because the technology sophistication was limiting the clinician as user applications. So for example, if you are creating an environment where someone is overcoming a phobia and they're standing at the edge of a cliff, there's no real alternative to doing that. And so if it's not a high fidelity experience in terms of technology, then you still get a great deal of benefit from that. So I talked about a few examples. There's PTSD, phobias, anxiety disorders, psychological interventions, and then just plugging an application that's happening in my own homegrown hospital. So Dr. Sachs is a neurosurgeon, and he uses VR for training and feedback tool in Parkinson's patients as they're undergoing deep brain stimulation. So then a bit about clinician as user applications. So this has had less focus in the past, but it's a new domain of growing applications. So all of the things that we saw today so far have been clinician as user applications. And it's an exciting place to be in because the technology is reaching a point where we can finally create things that are useful. So to have something adopted in the clinic, it has to be better than current clinical practice. And the technology has reached a stage where we can do that. One example is education. So teaching of anatomy, things like that. So early on, there was an article where the UCSF medical students were learning anatomy. I'm sure this happens quite a bit now in different institutions. There's also different educational platforms. So one example is in Duvo, they have like a VR authoring platform where you can create educational lectures by importing content and then talking about it and recording it, and people can play that back later. So there's different things that you can do with patient-specific clinician as user applications, and this stratifies as well, and it has to do with how much goes into the technology. So on the planning side of things, you can do strictly visualization, but then you can include interaction with models, right? So you can resize them very simply, or you could have like the cutting planes and things like that. And then you can implement simulation with these virtual environments. And so this really lives in a planning domain, which we think has a strong VR focus, because in this case, you don't need to interact with the real world. Then when you talk about transferring a plan to a patient, so in terms of an intervention, you have three main things that have to be accomplished. There is tracking, which is typically done by the technology that's there to date. And then registration. So there was the discussion of that earlier in terms of aligning a leg with a patient. And then guidance. So that's having the simulation or immersive environment guiding you towards making the interaction better. And so this largely has a strong AR focus, mostly because you're interacting with the real world. We tend to think that VR is a platform that has a lot of benefit for medical image interface. It provides true 3D visualization. You have multi-dimensional input with tracked hands and controllers. And you have the possibility for network to remote interactions. So you can share a virtual environment. So I'll just go over a little bit about a framework for modern technology that I find useful, and I'm also just trying to promote. So understanding modern VR and AR technology, it's pretty difficult in terms of how do you tell apart all the different applications that are there. So you have like the HoloLens, you have the AR kit, you have different VR headsets. What is it specifically that differ between these different iterations of the technology? And largely it comes down to three broad technologies. There's visualization and how that's accomplished, tracking and what that means in terms of the simulation, and then structure sensing. So being able to identify objects in the real world. So we can introduce a concept of virtuality, which is enabled by visualization technology. Perspective generalization, which is enabled by tracking technology, and then a concept of world cognizance, which is enabled by structure sensing technology. So low virtuality would be user sees entirely the real world. High would be the user sees entirely the virtual world. Perspective generalization, you can go from a fixed perspective where whatever virtual element you're seeing is locked to your head. As you move it around, it moves with you. Or a generalized perspective where the objects are fixed in space. And then world cognizance, you can have a world agnostic. So there's no interaction of virtual elements with the real world, or world cognizant, where virtual objects interact with real world objects. And so this creates this 3D space that you can use to distinguish the different pieces of technology. And so I have some examples here. So for example, Google Glass could be considered an augmented reality technology. And you can see that it's at the bottom corner there, where it's very low in virtuality. So you're seeing most of the real world. And it's low in perspective generalization because you have the field of view is fixed to what you're seeing. So if you move your head, it moves with you. And it does very little structure sensing, if at all. I guess you could consider the GPS that it had to be some sort of structure sensing. Oculus Go is a VR headset. So it's fully virtual, so high in virtuality. It's about half on the scale of perspective generalization because it tracks the rotation of the user's head, but not the translation. And it has no structure sensing. Apple AR Kit is another augmented reality example. In this case, we are around, because it's augmented reality, it's about half the scale of virtuality. It has quite a great deal of structure sensing, so it's high in that in world cognizance. But then it's only moderate in terms of perspective generalization. You do have a general perspective, but it's that of the camera on the device itself. And then Microsoft HoloLens is high in world cognizance, medium in virtuality, and then high in perspective generalization. And then in terms of the different iterations of the technology with VR and AR, it's useful to distinguish between two types of augmented reality. The first is pass-through. So this is basically having a VR headset with cameras on the front. So you get a mix of real-world images and virtual elements by compositing them in video. Or you have see-through augmented reality. So this is the HoloLens example, where you have clear glasses with which you view the real world for real. And then you have virtual elements that are displayed onto the lenses. One last piece of the puzzle in terms of distinguishing technology has to do with input. So modern VR and AR input allows for intuitive and information-rich input. So traditionally, when we interface with computers and their data, we're talking about things like computer mice. So in this example, there's only 2 degrees of freedom in terms of your input. So there's up and down and left and right. And then there are 3 buttons or more. When you talk about VR controllers, you can have 6 degrees of freedom, so translations and rotations, and any number of buttons. So all modern VR systems have these types of controllers. An example for an AR system, Magic Leap has them as well. And then you also have the option of hand tracking. So in this case, you have the same 6 degrees of freedom that you would with controllers, but you also have poses of the hands and how you might detect those. So the HoloLens and HoloLens 2 do that. Magic Leap, the Oculus Quest, and Leap Motion, which is an add-on device, enables this. Okay, so now we'll get into some background in terms of understanding what we're trying to accomplish with our company and the research that led to it. And it has to do with understanding how we can interact with radiological images in an immersive 3D environment such as VR. So we start with a raw image, which is usually in an international format called DICOM. And there's different ways that we can view this in a virtual environment. So one is using segmented or mesh models. So this is a workflow that's often used in 3D printing. I'll talk about it in a little bit later. Basically, you create a 3D mesh like you would have in a video game. You might refine it, and then you use it in some simulation. The next is viewing raw image data in an unsegmented image, or rather not doing the segmentation step, but looking at the image directly. So there's 3 ways you can parse this out. The first is 2D visualization, which is just a virtual screen or monitor. So it's basically doing exactly what we do in the real world, but putting it in a virtual environment. There's nothing really tricky about this. The next is this concept that we've introduced called the 2.5D visualization plane. So in this sense, you still have a 2D visualization. It's a 2D cross-section through a 3D volumetric image, like a CT scan. But in this case, the plane has some correspondence in physical space to the image itself. And so you can move that plane, and then you get a change in what it looks like. And the last is 3D visualization, which is accomplished by a technique called volume rendering, where you cast rays through an object, and then you create a 3D representation of that image from just the image data that's there. So I'll just show some video examples so you can understand. So this is what I mean by 2.5D visualization. The orange cube there maintains the CT scan as a volumetric representation, but you don't see any of it until the plane intersects with it. Then you see the cross section of the image as the plane moves through it. So there's actually some great benefit to doing this in a 3D environment because you have that spatial understanding of where things are and how they relate to each other. Because the plane actually has to move in space, you understand better what it is that you're seeing. So here's a comparison between 2.5D and 2D visualization. So here's that 2.5D plane that I was talking about before with the cube that holds the CT scan. And then on the right, you have an example of just regular 2D visualization where we basically bring in these image slices that don't correspond in physical space to anything in particular, but you can still scroll through them like you would on a normal computer screen. Oh, this one didn't play. So here's an example of volume rendering. So this is a CT scan that we did volume rendering with, and then we introduced this fun little concept that didn't have any real clinical utility of an X-ray flashlight. So I'll bring the flashlight in a second, and you'll see that you can basically peer into the patient's brain by having a fused MRI overlaid with the CT scan. And what the flashlight does is it reduces the opacity of the CT and it reveals the MRI with a different glowing color. So it was just basically a fun little concept that we made to show to the doctors that we were working with to try to get them to think outside the box and come up with new ways to interact with the data that they deal with on a day-to-day basis. And then you can combine these different visualization modes to come up with useful interactions. So this is an example of combining 2.5D visualization with models, right? So the model takes up the same space as the image and you view the image on the plane as you move it through while also potentially clipping the model. And then here's an example of a 2.5D plane with volume rendering. So in this case, the volume rendering is just showing the edges of the images and it's giving a contextual understanding of what transformations you're doing to that image cube so that you understand the corresponding cross-section better. Okay, so those concepts bring you to understanding what it is that we're trying to accomplish with our product called Elucis, which is enabling a new era of medical modeling. So just a bit of background, there actually has been some extended reality examples in radiology for quite a while, if you consider 3D printing to be that. So 3D printing is really about taking 3D content from an image data set and then bringing it into the real world, which is effectively what we're trying to do with VR and AR. And it's been around for quite a while. So earlier, Philip introduced the workflow that they did for their work, and it's actually quite similar to what's done for 3D printing. So you start with some volumetric image, like a CT scan, and then what you do is you segment it, and then you create models. So I just did a screenshot of what he was doing. We think that there's a disconnect between the objectives and the tools. So largely doing this work on a 2D screen removes a lot of the benefit that 3D provides. And so you're creating 3D content that helps people downstream, but you're doing that in a difficult 2D platform. So I'll just show a few videos of what we've made and how it works. So in this sense, we've combined the whole concepts of the 2.5D visualization plane. You can now input and draw on a hard surface that corresponds to that plane, or you can draw on the image itself. And you have these semi-automated tools that you would have in another 2D-based platform, but now you have true 3D input interaction with that. So here we're drawing, and I'm showing you a 2D representation as I'm drawing, but really what's happening is it's making a 3D model at the same time. So what we're trying to do is basically have it so that you're like a sculptor, and you're working with this image to create this content. So earlier, Dimitri said that there's a great deal of human intervention, even when you use automated methods. And it's enabling that human intervention that we're trying to accomplish, making it easier to come by, and in so doing, making medical modeling easier. So just a note here, we actually create no distinction between segmentation and the final mesh. So at all points, you actually have the final result, which is one of the benefits of what we've done by basically reimagining the whole process. So here you can see looks like it's drawing in 3D, but it's really making a 3D structure the whole time. You just choose to represent it in 2D or 3D at any given point. And then you can also have a number of modeling operations that are made easier by virtue of being in a 3D environment. So some of them are just menu driven, like creating shells around objects, but then you can have handheld clipping planes that can be used to make permanent cuts in models. So this is the type of thing that's very useful when you're talking about 3D printing so that you can see inside of a structure. And then we also have the capability of importing your own models. So if people have a workflow that works for them, or they have something that's not necessarily derived from anatomy, they can bring it into the platform and use it for either planning or deciding how they're going to create a certain structure or do an intervention. So this is just a little fun clip that doesn't have a great deal of clinical utility, but showing how you can interact with these things, and it makes it a great environment when you can create them quickly and then have them at hand right away. So here's an example of a little markup tool that could be used to leave notes for someone who's in the content creation process, or someone who's going to be using this content later, like a surgeon. We also implemented full remote collaboration. So this is something that we're really excited about because it enables a great deal of communication. So you can create the models as you're talking and interacting with people. So you can start from an image and quickly create models. Here's an example of a spine interventionist who was discussing how they do their imaging and how a different feature in the platform might be useful for them. So this stuff is really exciting in terms of the things that we're doing. Yeah, so I guess that's the end of the presentation. Any questions?
All right, thank you ever so much for that, Dr. Sutherland. We do have a question here from Mary, and I've actually got a couple of questions myself after looking into that, because I've thought of similar ideas before, but I've often questioned the clinical relevance rather than it just being a tool. So the question here from Merrick is, or Mary, have you considered an AR headset like the Varjo XR1 for applying mixed reality in the healthcare training solutions? It's an eye tracking in human eye resolution, which could prove very useful in such cases.
Yeah, so we are compatible with the Varjo. So our system basically runs on SteamVR. So any SteamVR compatible headset would work with it, which that happens to be the case for the Varjo XR1. There's also interesting things that you could do with eye tracking that we're not doing, but we've thought of. And so for example, radiologists, it's important that they look at all of the image that's part of their reading exam. And if you were to have a VR-based image reading platform, so you're replacing looking at a computer screen with putting on a headset, that's not what we're trying to accomplish, but someone might. Then you could use eye tracking to give them a check mark so that they can assure themselves that they've looked at everything.
All right, that's really good. My particular question actually was in relation to the tool that you've created. So have you looked into the opinions of clinicians about this tool and how they can possibly integrate it into practice in the future? Because I see this mostly at the moment as an educational tool. So for students or younger physicians who are learning or preparing for certain surgeries or learning about the anatomy of certain areas, they can use it to have that 3D sort of /2D representation of the human body rather than a textbook, which is inherently 2D or a flat screen. So other than the educational aspect, what kind of feedback have you gotten about the clinical world and how that can be translated into the clinical world?
Yeah, so there's actually a great deal of clinical use of this type of technology. Historically, it's been in the form of 3D printing. So people have started from images, they make 3D models, and they give them to surgeons to do surgical planning. In many institutions across the world, this is done on a routine basis. It's very common in pediatric cardiology, for example. So experts in 3D printing have said that it's now unethical to do a case of surgical intervention in pediatric cardiology without looking at a 3D printed model first. All the benefit that 3D printing provides in terms of surgical planning and visualization can be done with augmented reality or virtual reality. And so it's just enabling that whole domain that we're trying to do. In terms of feedback, so obviously we've had people using it at the Ottawa Hospital since the start when we started developing it there, but we have a number of customers and then trial users as well. And the feedback is that the content creation is made much easier as we had hoped, but then also it's a great platform for the interfacing and replacing maybe some of those 3D printing activities with a more virtual environment.
That's really good. When you mentioned the cardiac sort of pediatric 3D printed model, what I've seen previously is that they would print it and then in a 3D format, and then the entire team would work on pretty much simulating the surgery. So they have like a warm-up, if you like, of the surgery, or they do the entire surgery A to Z with the tools that they'll be using that 3D printed model. Is something like that available in using sort of XR technologies where different members of staff would use that as a sort of a pre-op preparation for the surgery itself?
Yeah, so that goes back to the slide that I had earlier where we talk about the visualization and then simulation and that kind of thing. So there are many cases where people just use this technology as a visualization tool, and seeing the plan, seeing the problem ahead of time makes them decide how they're going to go about it. So in that case, a fully immersive virtual environment that has no haptic feedback can fully suit those needs. Then when you're talking about having the practice on a printed model that maybe has flexible material, that potentially could be replaced by some sort of haptic feedback device where you have either a printed model in real life with augmented reality overlaid meta content, or you have a fully immersive environment where you're using a force feedback device that's basically simulating a surgical tool. There's various opinions on how useful that is in terms of maintaining fidelity with the real world. And I do know that there are some companies that are doing that to date. Largely, they're focused on training examples, but it's pretty obvious that they're interested in moving into patient-specific examples of that.
That's fantastic. Well, thank you ever so much for your time. I really appreciate it. So now we just wanted to see if there's any particular questions for any of our speakers, guys. Feel free to put it in the chat. And if not, we're posting the links for the feedback form. And if you'd like a certificate, we've posted another link for that as well. Obviously, we don't have any funding. We're not affiliated to any official bodies or anything like that. So we don't charge for any of our events, and our speakers kindly have done this voluntarily, as far as I'm aware anyway. So what we'd really appreciate is just some feedback from you guys. That helps us tremendously, just showing the university that there is a demand for our existence essentially as a society, and the same applies to the Radiology Society and University of Birmingham Virtual Reality Society as well. So if you can please fill that out, it would be fantastic. If you've got any further questions for the speakers, do please post it on the chat. There is a link available at the moment on our Facebook, so that's Leeds XR Society. The event is being recorded live, so hopefully you'll be able to check that out once we've ended the event. And if any of our speakers would like to mention anything, feel free to do so. Perhaps you can elaborate a little bit on the haptics aspect. So that seems to be quite a big barrier at the moment. A lot of the things that we do in surgery or in this sort of VR realm within medicine and surgery is very much not based on a 3D sort of device or something that can give you feedback. So have you looked into working with the likes of Fundamental VR, who do use like an arm kind of thing to give you that haptic feedback, so you can combine the image along with haptics? Or is there something else like a haptic glove that you guys are working on?
So we're not doing anything in that domain at the moment. We're always open to working with the surgical simulation companies in terms of enabling the stuff that they do and kind of melding of the minds in terms of technology. What we're really focused on right now is solving that first piece of enabling the human intervention in terms of creating the content. And then from there, since that's the beginning of the workflow, then you can start implementing new technologies on top of that, right? So start with creating the static model, and then on top of that, you have simulation properties, then haptics comes into play. Eventually, you could have evaluation things as well, right? So putting in like hitboxes and things that you touch, and then it has a check mark. Ultimately, what we're trying to do is just create the tool that enables everyone to create the content that they want. So whether that's haptics or not, but right now it's just all on visualization.
Yeah, so we used again in medical education for palpation practices. We have tried a haptic glove to give you the force feedback. So you had a virtual anatomy model, and we used, I don't know if I can plug products here, but we used a Sense glove, which is a 3D printed haptic feedback glove. So at a very low price point, because haptic feedback devices can be quite expensive, and yeah, Fundamental VR does a great job, I think, in creating these simulations. But yeah, they're at quite a different price point that we are aiming for our education at the moment, at least. But I think haptics and haptic gloves have a long way to evolve to be really practical, especially also for training. So I really like the setup where we had this phantom and a real needle, and create a force feedback like that. It's a very sort of bare bone approach, but it gets the job done really, really well, and it makes it more scalable to do it that way. So if you introduce something like an haptic glove in your simulation, you must provide it to everyone for use. So creating a more simpler phantom and getting the force feedback from that was actually, I think, a very nice approach that we are looking to do more of.
Okay, that's great. Thank you for that. Hopefully, some of the frugal designs and the companies that are working on frugal designs and sort of, you know, simpler, cheaper sort of components do grow quickly so that we can add it to our clinical work. There is a question which I actually have thought about a lot myself as a medical student. Obviously, this kind of thing, unfortunately, isn't covered in our standard medical curriculum, far from that. And I would assume it's the same as you guys were undergraduates or in your earlier stages of training. There wasn't any of this education about these technologies, etc. So the question is, that's quite a heavy, novel skill set. I'd like to start with learning. Oh, sorry. Yeah, the question is there any advice or tips you can give to medical students regarding learning the coding or the machine learning aspect behind this? I'm really interested in developing the skill set to understand more complex computing / maths or engineering behind this. So do you guys have anything to share?
Well, one thing I would say is, you know, if that's something that you really were into, then certainly there's better experts on the panel than me. But I would also say that the great thing about this is actually collaboration, and it was working as part of a team that made our first publication really successful. You know, there's no way on earth that I could program as intelligently as Philip can, and working with Thomas doing the educational stuff, he's got really good educational understanding, and actually this isn't about being one great human being that can solve everyone's problems. It's about working as a team and everyone providing their bit that can make actually the best possible device or product or whatever you're trying to do. So that's the bit I would take out of it, is work with people, talk to people, share ideas, and that's why I think you've got a really great society here, because it's so multidisciplinary.
So I would add a plug for Unity for sure. A lot of the video game engines that are out there, like Unity and Unreal, they make this a really easy endeavor in terms of getting started. So for anyone who's sitting on the fences, interested in learning how to code and how to do this kind of thing, it's a lot easier to get started than you think. They have tons of tutorials and resources, and a lot of the interactions in terms of how to make this button do this thing in VR is handled by libraries that are already out there. So definitely Unity and C# are the way to go.
Yeah, and you can you don't even need a device now. You can use emulators to get up and running. So you can sort of test things out before shelling out on a reasonably expensive device. Yeah, I think with computer graphics in general, just to have a sort of a good appreciation of sort of basic linear algebra in terms of vectors and matrices and coordinate transformations and so forth is helpful. It's not strictly necessary, because a lot of that's kind of hidden under the surface if you use these engines. But it's always good to understand what's actually going on. You know, when you come to debug things, it's if you know what's going on under the bonnet, you can often get to the problem faster, rather than just sort of a more trial and error type approach. So having that baseline of mathematical fluency is to be recommended.
That's fantastic. Thank you very much for that. We've got some other points as well from the chat. So thanks for everyone who's contributing. I'd like to thank you all for dedicating time and for sharing such amazing research. It's honestly so inspirational. I'm pretty sure that 10, 15 years ago, students didn't have the ability to access such knowledge base and skill sets and amazing work. So I'd like to thank the attendees as well for attending. I'll hand over to Anna, our president, and then the other two societies, if they have any final words to share, and then we'll probably call it a day. Over to Anna.
Thanks, Mohammed. And yeah, massive thank you on my part for all the speakers and for all you attendees for coming today. I've really enjoyed this collaboration. I think this is one of the ways that societies can grow stronger and grow and expand across the country as well. So it's been a really great event. So thank you very much. And if any of the other societies would like to say goodbye, then I'll pass over to them.
Yeah, so yeah, I echo what Anna said. Thank you very much to all the speakers. It was really useful. It was really interesting actually to see like what crazy stuff is going on in the world, because yeah, especially in this year where we can't do anything in person, it's good to see that we can still kind of explore new things online. And it was really good to collaborate with these two societies, both Leeds and Birmingham XR societies.
That's great. Thank you so much, guys. That will be all from us. So yeah, do follow all of our societies on our social media, and yeah, we will all be in touch with our next events and what's going on. But for now, have a great afternoon, and we will see you in the future.